Dravet syndrome is a type of epilepsy that presents in the first year of life. Children have previously been normal and present with often febrile, long seizures, often lateralized seizures that often require admission to the intensive care unit for treatment. These are recurrent, and then in the second year of life they have the emergence of other seizure types, and what also becomes apparent is they experience a developmental slowing, and in the long term have an extremely poor prognosis for their neurodevelopmental outcome as well as seizure control. Dravet syndrome can be difficult in its classical form to diagnose at the outset. It was first described by Charlotte Dravet, who, in watching children at the centre in Marseille where she worked, felt there was a very different phenotype to those that have been more classically described as Lennox-Gastaut, and hence the description of this very specific phenotype, previously called severe myoclonic epilepsy of infancy, but now to be more descriptive and more encompassing is called Dravet syndrome. The diagnosis can be difficult. We have to do it on the basis of electrical features and clinical features, predominantly clinical features, the pattern of the long seizures, the pattern of ongoing emergence of different seizure types. But the difficulty we have is the fact that they emerge with multiple seizure types and have the developmental slowing. How much the different seizure types are causing the developmental slowing and how much that is due to the genetics of the individual is really unclear at the present time. Diagnosis can be difficult, and the issue is we want to be very specific in the diagnosis to know which treatments they may or may not respond to, and therefore we don't want to lump them all together amongst a whole group of different diagnoses. We want to be very, very specific so that we get clear data in going forward. It's an electroclinical diagnosis, it's a syndrome diagnosis, of which in the classical form 80% are associated with a sodium channel mutation at SCM1A on chromosome 2. However, there are a whole range of individuals, perhaps with variable phenotypes that may have an associated gene defect, and others who have the true electroclinical syndrome that may have other genetic defects. So it is very difficult at this stage to give the true prevalence. What we do know is that in the past, these children were probably lumped together with the likes of Lennox-Gastaut syndrome, and therefore, whereas that was thought to be one of the more common complex epilepsies, it's likely as we get more definitive in our phenotyping and definitive in our clinical description of these children, that Dravet is one of the more common, difficult, complex epilepsies to treat, affecting around 1 in 30 to 1 in 40,000 children, and Lennox-Gastaut in its true form is actually extremely rare. The challenge for us remains in treating the individual specifically for their seizures, making sure their seizures are controlled. We know which medications may help. More importantly, we know which medications may make them worse, and we want to avoid that. Certainly, their onset of neurodevelopmental slowing comes on at a time their seizures become more manifest, and this has therefore been thought to be the archetypal epileptic encephalopathy, that ongoing epileptic activity is having an impact on neurodevelopment. So our goal has been as much control as possible of seizures, optimal control of seizures, and the challenge has been finding the treatment that may do that for us without resorting in polypharmacy, or indeed actually achieving that goal. In some children it can be extremely difficult. Therefore, our challenge does remain in finding treatments that optimise the seizure control and maybe therefore have an impact on their long-term neurodevelopmental outcome.